Welcome to the Just Hard podcast, where real nurses have real conversations about the tough stuff. Because in nursing, hard isn't the enemy, it's the making of you.
We're your hosts, Chelsea
Chelsea
Justice, the best ever, and I'm Lisa Harding. We are two nursing faculty who believe in teaching with honesty, heart, and a whole lot of practical wisdom. We know that nursing school isn't just challenging, it's transformative. And we're here to make that transformation clearer and more doable, and yes, even have a little fun.
Every episode will break down the hardest concepts in nursing, show you how they actually will show up in clinical practice, and give you the tools to think like the nurse that you're becoming. We'll share our real-world stories, the lessons we learned the hard way, and the moments that pushed us and our students to grow.
So settle in, breathe deep, and remember, it's just hard. And we can do hard things.
Let's get started.
Let's go!
Welcome to the Just Hard podcast. Real nurses, real talk, real life, where we take the nursing textbook and drop it right into the hospital unit. Today, we're tackling liver failure, ascites, and spontaneous bacterial peritonitis, aka the sneaky killer that students often overlook until the patient is tanking.
If you've ever thought they don't have a fever, so infection is unlikely, this episode is for you. Okay, let's drop into a real bedside moment. You receive a cirrhotic patient with huge distended abdomen. They're a bit off mentally, slow to respond, mildly irritable. Their family says, he just isn't himself today. So you might be thinking, what are the vitals? Well, you take their vitals, blood pressure 90/54, heart rate's 112, temperature is 99 degrees Fahrenheit. We probably should learn that in Celsius, I guess. Respiratory rate's 22 with a SpO2 of 94%. The labs are pending. What are you thinking?
Not good. I am concerned. So I'm thinking sepsis and maybe related to spontaneous bacterial peritonitis.
Cirrhosis patients don't always mount a fever. They can be normothermic or hypothermic and still septic. And that mental status change, that's a red flag, not an afterthought.
So let's break down some of the pathophysiology. So quick science moment. Why do they get ascites?
Portal hypertension plus low albumin, the fluid leaves the vascular space and collects in the albumin. Also, the kidneys freak out, trigger the RAS system, the renin-angiotensin-aldosterone system, and hold on to sodium and water, making it worse.
So we get third spacing, hypotension, fluid in all the wrong places. And remember, with third spacing, that fluid is just sitting there. It's not doing us any good.
Sitting around waiting to do something bad, I think.
Yep.
So what are our early bedside priorities? What do we do first? We don't panic, we prioritize.
We might panic on the inside, but we're not going to show that.
That's a never let them see you sweat moment,
Yes.
isn't it?
Yep.
Fake it till you make it. That's what I always do. So let's start with our neuro assessment. In this one, subtle confusion matters. Then we go to vitals plus perfusion. Think about your map, not just your blood pressure. So remember what your mean arterial pressure is. Then we want to do an abdominal assessment and girth. It's where we get to go out and get those old school tools called the measuring tape and measure that abdomen and see how big it is. Review our diuretics. So we're going to look at spironolactone. That's going to be our hero in this story. And then we want to restrict salt. So we got to educate our patients about salt restriction.
And then the big one. What if we suspect that our patient has spontaneous bacterial peritonitis?
Diagnostic paracentesis.
ASAP. So we're going to address a couple of misconceptions. So sometimes students say, let's get a CT scan first.
Nope. Paracentesis first. CT does not diagnose spontaneous bacterial peritonitis. We need that ascites fluid for the PMN count and to get a culture.
So a PMN count greater than 250 cells means spontaneous bacterial peritonitis until proven otherwise.
Exactly. Students always ask, Is a paracentesis dangerous? What if they bleed?
Well, we always have the risk for complications. It goes back to our risks versus our benefit for the patient. The paracentesis would be done with ultrasound guidance and a trained provider. It is safer than not doing it. Of course, we would want to check some of those things like our patient's platelet count and consent and all of those things before the procedure. And then what else is it that we would be thinking about potentially giving after pulling off a large volume of fluid?
This is such a great question because as a current radiology nurse working in the procedural area, I do paracentesis multiple times a day. And oftentimes I might pull off 14, 15 liters of fluid. So when I pull off large volume paracentesis, I have to think about replacing albumin. Albumin is my full fluid pulling friend that keeps my blood pressure from crashing. So when I take off a bunch of fluid, even though it's in the peritoneal space, it's still volume depleting, and I have to replace that albumin.
Absolutely. And a lot of times it's us as the nurse that are asking the doctor ahead of time, anticipating those needs. Hey, are you wanting to give some albumin during the procedure or after? What are you anticipating? So anticipating those orders is key.
Absolutely. And a lot of hospitals actually have protocol that says if you draw off X amount, then you replace with X amount. So it's actually cookie cutter, but we always, as the nurse, that's our job. We got to anticipate that and implement that plan.
Absolutely. Okay, listeners, quick quiz. In liver failure, what improves your patient's mental status? Lactulose or albumin?
Ooh. Well, always lactulose.
Always lactulose.
Yeah, we don't titrate lactulose to diarrhea. We titrate to 2 to 3 soft stools per day, and we look for improved mental clarity.
So lactulose binds to the ammonia and the patient poops it out. So that ammonia is very, very toxic for our patients. So we have to give them the lactulose. If your patient says, I don't want to take it because it gives me diarrhea,
No duh.
yeah, that's the point.
That's
So
the
2 or
plan,
3
Stan.
episodes a day. It doesn't have to be 10.
Right. Yeah,
Right.
10's too many. You might get a rash. Yeah, I often find that with my students in clinical, they see lactulose and they think, oh, that's part of the bowel protocol.
Mm-hmm.
But in patient-specific medication administration, lactulose is the key, isn't it?
It sure is.
So you walk in and the patient suddenly won't answer orientation questions. You check ammonia?
Well, we want to complete our assessment, and then an ammonia level would be appropriate. It doesn't always correlate perfectly with our patient's neurosystems. We need to think about, could something else be going on? Is it spontaneous bacterial peritonitis? Are they going sepsis and having altered mental status because of that? Or is the ammonia high, or is it both?
Oh, so assess first, treat first. Okay, so say it again for the students in the back.
So we want to treat the patient, not the numbers. So we need to complete our full assessment, our full neuro assessment. And one of the tricks that we can do with our assessment without even drawing an ammonia lab is you have them hold their hands out in front of you and see if their hands shake. That's called asterixis,
That's
or
such a
the
cool
liver
name.
flap.
Liver flap.
Yep. So if your patient holds their hands out in front of you and they have that liver flap where their hands are shaking, that could be an indicator that the ammonia level is high, and then you would get the lab test to confirm.
So once again, treating the patient, not the
Yep,
number.
yep.
I like it. So have you ever noticed that families get scared and say, why are they confused? Why are they so swollen? What do you tell them?
A lot of times your families do notice that, and they worry about the things that, they want to be able to control. Why are their hands cold? Why are they puffy? Well, we just have to educate them realistically and compassionately. So we could say something like the liver helps clear toxins and manage fluids. Right now the liver is struggling, so the toxins are building up. And our goal is to help support the body and prevent them from developing any further infection or complications.
I love that, Chelsea. It's simple, it's honest, and it's therapeutic. You can hear your compassion, and that's really what matters in this.
All right, let's finish our case. So we advocate for a paracentesis. Fluid comes back. PMN is 600. Remember, we said greater than 200 was indicative. So we have confirmed the patient has spontaneous bacterial peritonitis. We're going to start antibiotics, often ceftriaxone, and watch their neurostatus like a hawk. Couple hours later, the blood pressure stabilizes and your patient is more alert.
Because you caught it early. Way to go.
Way to go.
Whoop, whoop.
So a couple of key points. So your liver patients can develop spontaneous bacterial peritonitis, just like the name implies, spontaneously. They may have never even had a paracentesis before because that fluid is third spacing and it's just sitting there, and it's a high risk for infection, translocation of bacteria from the gut. So even if your patients never had a paracentesis or an invasive procedure, they're still at risk.
Yeah, and then another pearl to remember, not to forget, mental status changes are early warning signs. So if we're anticipating, we're looking for those sneaky little signs, mental status changes are early in this liver failure patient.
And we also want to remember that with your patients with liver disease, they often, even though they're fluid overloaded, that fluid is in the wrong space and they could be depleted intravascularly. They've also lost a lot of sometimes their body muscle mass, and their metabolism is down. So they might not have a fever. These patients are often actually hypothermic. So you got to be really careful when you're looking for sepsis in these patients.
Yeah, that's that immune compromised thing that chronic illnesses lead to. Yeah. And then I always notice now that abdominal girth is basically considered a sixth vital sign in a liver failure patient. So we need to add that to our little toolbox, I guess.
Yep, and we want to make sure that we are measuring it consistently. We might have to put some markings on the abdomen so that each provider that goes in the room is seeing the same measurements. That would be something that we could do with the offgoing nurse too for our handout.
Yeah. Awesome. Well, thanks, Chelsea. It was a great discussion today
Thanks.
on peritonitis and what we look for in the ascites patient.
Yes, and we will tackle pancreatitis next week.
Yes, let's do it.
And now a word from our unofficial sponsor, who absolutely did not pay us for this.
Lactulose, the sweet syrup that tastes like sadness but saves your brain.
When your liver can't handle ammonia, lactulose steps in like, don't worry, boo, I got you. It pulls that ammonia straight into the colon and
Escorts it out of the body quickly, sometimes very quickly.
2 to 3 soft stools a day. That's the goal, people. Not 0 and not 10. Not a crime scene.
Side effects may include cramping, bloating, and a sudden fear of being more than 10 feet from a bathroom.
But hey, clear thinking, less confusion, avoiding hepatic encephalopathy, totally worth it.
Lactulose. It's not glamorous, but neither is ammonia.
Welcome back to Just Hard, the podcast where real bedside nursing meets real talk. Today, we're tackling one of the most intense abdominal emergencies you'll see, acute pancreatitis. High pain, high inflammation, and high risk if you miss the early warning signs.
And we're breaking down exactly what you need to know in the first few hours, when good nursing literally changes outcomes.
Picture this. Your patient is doubled over, pale, sweating, never a good sign. Heart rate 128, sinus tach, saying the pain shoots straight through their back.
Lipase comes back 1,200. Calcium is 7.1 and hematocrit is rising. Ooh.
That is textbook acute pancreatitis, and this is where nurses matter.
So what exactly is happening? Pancreatitis basically means the pancreas autodigest. I kind of think of it as I'm eating myself, like I am the carnivore of my body, right? I'm cannibalizing myself. The digestive enzymes activate too early and the pancreas starts eating itself. The pancreas basically like fat and carbohydrate rich, and so we secrete those enzymes and they start acting on our pancreas, digesting fats and carbohydrates.
It's a huge inflammatory storm, and that inflammation wreaks havoc everywhere. So, not just the pancreas, lungs, you can actually get pleural effusions that have pancreatic enzymes. When you drain that fluid and test it, it can send them into acute respiratory distress syndrome. It can affect the kidneys, the electrolytes, everything.
A rising hematocrit is your first big clue. That's called hemoconcentration, if you need a fancy word for it.
So they're losing the fluid into their tissues, third spacing like crazy. So they look dry, their blood pressure drops, and their lactate climbs.
And this, associated with their high pain levels that they have, is why they become super tachycardic. But it's also why we have to hit those fluids early, but we have to hit the right fluids.
Right. So which fluids do we choose, LR or NS? So the single most important nursing decision early on is we want to help advocate to get lactated ringers instead of normal saline.
Yeah, that's one of the most common mistakes because we like to grab normal saline because it's everywhere and it's easier and it's compatible with most of our medications that we give. But in this case, it is not your friend in pancreatitis.
Exactly. It has a super high chloride load. When you dump that much chloride into a patient who is already inflamed and acidotic, you actually make their acidosis worse.
And pancreatitis patients love to get acidotic.
So LR is the best choice because it's a more balanced crystalloid. It has electrolytes closer to what's in the plasma, and the lactate in the LR gets converted into bicarb, which helps buffer your acidosis in your patient.
I love how our previous knowledge of acid-base balance kind of comes back around when
Yep.
we study. It's everywhere.
There
It's
was a
everywhere.
reason we made them learn it.
Exactly. So, in real words, normal saline will tank their pH, and lactated ringers helps to stabilize
And the
it.
data supports it. Lactated ringers reduces sears, lowers inflammatory markers, and is tied to better outcomes.
It sure does. So, early aggressive fluids, yes, but LR, always LR, unless there's some weird contraindication, which we're never going to see that on NCLEX, are we?
No, in the real world, we might have to think about that. What if my patient has more things going on? What if they're also in some type of renal failure along with it and their potassium is high? Lactated ringers might not be the best choice for them. So always remember patient specificity, but your go-to in acute pancreatitis without contraindications, lactated ringers. We've got to give them those fluids.
Yeah. Hey, Chels, why does the calcium drop?
Well, that calcium of 7, that is fat saponification.
That's a big fancy word.
It is. The inflamed pancreas is breaking down fat, and the free fatty acids bind calcium.
Low calcium in pancreatitis is basically your red flag for severity. If it's dropping, this inflammation is bad.
So, rising hematocrit, low calcium, all bad signs. So, one of the things too is we also have to take care of our patient's pain. Their body is eating it, their pancreas is eating itself. So, this is very, very painful for the patient.
Yeah, I mean, my time in the ER, probably, and you in the ICU, one of the most painful things I've seen in a patient is pancreatitis. That it looks miserable. Don't put me down for that.
Yeah, absolutely. And there's a lot of bias too from providers because one of the most common causes, not the only cause, but a very common cause is the alcoholism and alcoholic pancreatitis. And so a lot of times these patients really aren't medicated appropriately for the pain that they are experiencing.
Yeah, that's true. A lot of times they think that the opioids worsen the pancreatitis, don't, but they don't, and we're done with that.
Yep. So we need to treat the patient, treat their pain. The pain is what the patient says it is. Also manage their nausea. They can be quite miserable. One of the other things too is when we say that the pancreas it's eating those fats and those carbs, those digestive enzymes. Well, a lot of times these patients are made NPO because we thought that they would eat. It stimulates them to release more of those digestive enzymes, but that's actually changing a little bit, right, Lisa?
It sure is. You know, like when Florence Nightingale and I were nursing students together, when we were studying and then we became working partners. I'm totally kidding. If you don't know us, she's dead and old. I'm still alive. But anyway, I remember we used to keep patients NPO for days. It was a thing. It was a thing like NPO. You got pancreatitis, NPO, because even the smell of the food does in fact cause you to release those digestive enzymes. But we don't do that anymore.
Yeah, we feed them a little bit earlier now. We might go slow, not a whole lot, but just enough so that we can stimulate the gut, which prevents bacterial translocation. cuts down on necrosis and lowers mortality.
And that's really the goal, right? We don't want these patients to die.
Absolutely. If you do have a patient that can't tolerate anything and they need to be NPO for days, we can put in a feeding tube that's post-pyloric, and the idea behind that is that we'll actually not stimulate those digestive enzymes as much, and we can still give them some feeding in that way.
Yeah, and I suppose if we really needed to, we could give them TPN or partial parenteral nutrition too. I suppose we could do that too. But yeah, we really want to give them that.
Yeah, TPN is always a last resort. It's such a high risk for infection, and I hate TPN.
And it's not compatible with anything. It's so inconvenient. So inconvenient. I agree.
Yep.
So if they're vomiting nonstop, okay, hold off. But if they can tolerate even clears, we should feed them.
Sounds good. So other thing we need to worry about, respiratory. One of the sneakiest complications is respiratory failure.
Of course you would come up with that, you little ICU nurse, you. So if they start breathing fast and need more oxygen, or you're hearing new crackles, think systemic inflammation hitting the lungs.
And we haven't covered this topic in our semester yet, but in fourth semester, you'll learn about it in great detail. But ARDS, acute respiratory distress syndrome. And basically, that's what we saw with COVID with our patients. It's a bunch of fluid in the alveoli, and it's very, we really got to treat it early. And so our job working on telemetry with these patients is to catch those signs quickly. Don't wait for them to crash. Early intervention. Always be on the lookout, anticipating worst case scenario.
Yeah, crackles means fluids. And so if we hear that, we know they're crashing. Yeah. So let's think about labs. This is where we really need labs with Loken, right?
Yes.
Like Loken, she's a genius when it comes to labs. But anyway, so what are the labs that we actually care about? We talked earlier about the hematocrit. So if the hematocrit is rising, we think hemoconcentration. We talked about the calcium dropping, and that's because of the fat necrosis that we have. Lactate is increasing. Now, it's easy to think, and we should be thinking if we've got an infection or pancreatitis, if we're thinking about this, like, is my lactate rising because of sepsis? Obviously, think sepsis, save a life. That should be always the thing on our forefront of our mind. But in this case, when the lactate is increasing, we're thinking about hypoperfusion, and we know that the patient is going into lactic acidosis because of that. So we also want to look at those electrolytes, potassium, magnesium, and calcium. All of them can tank and drop. Glucose, well, pancreas, pancreatitis, glucose, usually we see this really, really high. And we will see an increase in our lipase. And so the lipase really isn't something that we're going to treat. It's not like we're going to give them a lipase binder or anything. But we really look for the lipase really for the diagnostic criteria.
Yep, lipase is pancreas specific. Also, urine output. If your urine output is dropping or your mental status is changing, think that your patient is not perfused enough. Always look at your patient. You can see so much more from looking at your patient than you can from the numbers sometimes.
Yeah, so true. Patient, right? And every patient is going to do something a little bit sneaky, a little bit different.
Trust that nurse's intuition.
Yeah, so some take-home pearls that we want to know. Lactated ringers over normal saline, we do that to protect their pH. Rising H&H, hemoglobin and hematocrit, is bad. Bolus them early, but reassess constantly. Don't ignore those respiratory changes. Listen for crackles. Look for those red flags. Early feeding saves their gut integrity. Opioids are safe. Don't get into the trap. And our patients now, they're so afraid they're going to get addicted or hooked or something like that. We've got to educate. And low calcium means there's severe inflammation. This is a super dangerous red flag that we got to walk in.
So that was your crash course on acute pancreatitis. This is a diagnosis where we as nurses can literally change the trajectory of the disease process and notice those early signs and act quickly for those prompt interventions.
Yeah, and if you haven't heard this podcast and you hang 3 liters of normal saline, you're going to have a bad time.
And if you liked this episode, send it to the coworker who still orders NS out of habit.
And if you didn't like it, we'll just assume your chloride is high.
See you next shift.
Bye-bye.
This episode of Just Hard is brought to you by pancrealipase, unofficially, because sometimes your pancreas just taps out and the rest of your GI tract has to pay the price.
Pancrealipase, For the patient whose stool is so greasy, the toilet is filling a workers' comp claim. Oh, no, I guess it's filing a workers' comp claim. And it's filling the toilet.
Or filing.
Yeah.
Do you have chronic pancreatitis? Are you tired of floating stools, food that mysteriously appears 100% undigested, or leaving behind skid marks that could qualify as environmental pollution?
Then ask your provider if pancreolipase is for you. Because taking your enzymes with the first bite of food is cheaper than replacing your entire plumbing system.
Side effects may include forgetting to bring the bottle when you go out to eat, arguing with your dietitian about high-fat meals, and the sudden joy of having normal poop again.
Pancreolipase, making digestion happen because your pancreas won't.